Oncology for the Inquisitive Mind. Your two favourite co-hosts, Dr. Joshua Hurwitz and Dr. Michael Fernando, are here to finish off the ASCO series. Unlike last year and the year before and the year before that, this one didn't go for eons and cross into the next year. We've kept it short. We've kept it sweet. It's 3 episodes. If you've missed any of our previous ones, go check that out. They're nicely edited. They're also on YouTube. But before we move on, Michael, it is so good to see you. This is the ultimate episode. All the really incredible, juicy things from ASCO. Are you excited?
I'm so excited, Josh. And I am very pleased with our fairly rapid transit through ASCO. Like you said, it has been short and sweet, but we are getting to the pointy end of the spear, as it were. And this is the plenary. This is the stuff that got tongues wagging and people applauding, dancing in the streets, questions asked at Parliament, all of the stuff.
Amazing. Questions asked at Parliament. You know that. Maybe Taylor Swift was there. But why don't we get started?
Absolutely. So we've got 5 studies. And the first one, I'll share the screen, and because we subscribed and we got some support to attend ASCO virtually, we have access to the slides which we're sharing here. But the first one is in an area of huge need. And I think in previous years, Josh, when we actually went to ESMO, and there was the cervical cancer chemoimmunotherapy study. That was really nice to see, get a plenary Guernsey, as it were. Well, this is poorly differentiated or dedifferentiated liposarcoma, and it is the use of abemacicilib. This is SARC 041, presented by Dr. Dixon from Memorial Sloan Kettering, and it is not an overstatement, I think, to say that this is a wonderful, fantastic, truly game-changing study. So the background here is that sarcomas account for about 1% of all cancers. They are rare, and we've talked about them once or twice since we've been doing this show, that in that 1% there are, more than 100 subtypes of sarcoma. So doing any sort of major phase 3 studies is a huge accomplishment just by itself. Just recruiting the number of patients in order to get to the statistical requirements is a massive achievement. Liposarcoma is one of the more common subtypes, and they most commonly arise from the abdomen and the retroperitoneum, and they typically contain both a slow-growing, well-differentiated component and a far more aggressive, dedifferentiated component, which I will now call DDLS from now on. Surgical management and surveillance remain the standard of care for sort of operable disease, and that has been the case for a very long time, but equally as long has been the use of single-agent doxorubicin in the first line as standard of care. That's been the standard of care for more than 50 years. Based on historical data, the overall response rate is about 6%. Median progression-free survival for dedifferentiated liposarcoma is between 2 to 4 months. In the second line, you've got things like eribulin and trabectedin in that line, but these give you a PFS of around 2 months. So abysmal, I think, is the word, Josh, that we throw around to describe these sorts of cancers. Now, what is interesting is that systematic genomic sequencing has found high levels of amplification in CD4 in nearly all liposarcomas. And CDK4 inhibitors have been effective both in vitro and in vivo. There were 2 phase 2 trials in dedifferentiated liposarcoma that effectively doubled that PFS of 2 months to 4.2 months. And there was a phase 2 clinical trial of abemacicilib, which had a median PFS of 7.7 months. So all of a sudden, we're seeing this improvement using drugs with which we are very familiar. Abemacicilib was chosen for SARC 041 because it is the most CDK4 selective inhibitor available. And it's available in a continuous daily dosing form. And it was compared here with placebo because the opinion of the authors was that the toxicity outweighed the benefit. There was crossover design, so do keep that in mind when we get to the numbers. The key eligibility criteria, pretty standard stuff. You had to have recurrent or metastatic dedifferentiated liposarcoma. Patients who had purely well-differentiated were excluded. I'll be honest, Josh, I don't know enough about sarcoma to know how they selected patients who were purely well-differentiated. Maybe it was something to do with the tempo. Patients had to have progression of disease by RECIST 1.1 in 6 months prior to study entry, so that's probably how they figured it out. Any number of prior therapies were included, and I think we'll see that a significant proportion of patients were actually untreated. And exclusion, rather reasonably, patients who had extensive disease needing immediate treatment, because at the time, they didn't really know how it would work. And this is the study schema. So patients were randomized 1-to-1 to receive abemacicilib or placebo. And I want to draw your attention to the dose, which is 200 milligrams twice a day. And Josh, in breast cancer, we do use a slightly lower dose. So this is a slightly higher dose of abemacicilib. And assessments were undertaken every 6 weeks for 36 weeks and then every 12 weeks. So as we said, prior lines of therapy was pretty even, but half of the patients had never had treatment before in the sort of unresectable space. So this is a untreated cohort, you could say, and even the patients who had lines of treatment, they were probably not very far into their journey. So now we come to the results, and we do love a very nice Kaplan-Meier curve like this. So this is the primary endpoint of median progression-free survival. For abemacicilib, it was 9.7 months, and for placebo, it was 1.5 months. And it's interesting as well, we talk about the placebo being chosen because toxicity outweighed the benefit. We're seeing that here, given that the lower end of what you would expect from single-agent doxorubicin is 2 months. So you're getting the effective difference between doxorubicin and placebo is, at minimum 2 weeks effectively. So that in itself is interesting, but you can see that abemacicilib is both numerically and statistically far superior. Hazard ratio of 0.38 with a p-value of less than 0.01. 60% of patients were alive, still on treatment, hadn't progressed at 6 months. In the abemacicilib arm. In the placebo arm, that was 22%. And the 12-month PFS in the abemacicilib arm was almost 40%. I should mention as well that I said earlier about how rare these cancers are and how difficult it can be to recruit. They recruited 108 patients for this study. So impressive, but small numbers. Here we have the response rate. The abemacicilib overall response rate was 9%, so not great, but the placebo overall response rate, I should say, was 0, absolute 0. Now, we mentioned before that a significant the crossover was allowed, and 85% of patients in the placebo arm crossed over to receive abemacicilib after progression. And the median PFS after crossover was 3.4 months with a response rate of 4%. So there is still some effectiveness even after progression, albeit on placebo. The overall survival, amazingly still immature. The overall survival in the abemacicilib arm was not reached. The placebo arm was 25 months. So, this is not a rapidly lethal cancer in the same vein as pancreatic cancer. More to come on that later, of course. But it is something for which abemacicilib can have a sustained benefit with a hazard ratio of 0.55 over placebo. 72% of patients in the abemacicilib arm were alive at 24 months. By prior therapy, for patients who had no prior lines of therapy with abemacicilib, the median progression-free survival was 16.4 months. So that's higher than the intention to treat arm. So you can see that is probably driving the majority of that benefit, and does make the real important distinction that abemacicilib sequenced is probably most effective in the first line. it's most effective as first-line treatment. But putting it second line and beyond, where the median progression-free survival was 5.3 months, so, almost a year less, is a significant downgrade. So I think for dedifferentiated liposarcoma, the writing here is really on the wall that abemacicilib should replace doxorubicin as first-line therapy. The toxicity, pretty straightforward. We know abemacicilib. We know that diarrhea is a major issue. We know that cytopenias are an issue, although perhaps not to the same extent as ribociclib. In this study, close to 40% of patients with abemacicilib had required dose reductions. But that's something that I guess is not unexpected. So a couple of limitations for this study. This was an American-only study, and there was no central pathology review, although, as is the case with sarcoma, I suspect pretty much all over the world, all centres that were involved were sarcoma specialty centres, and we have that in Australia, with pathologists that have experience in assessing sarcoma and its various complexities. But Josh, this is a fantastic study. I really liked it. I really liked that sarcoma got a mention. And, after 50 years, I know you love telling the story of the development of ADT and how that has been the standard of care, or a part of prostate cancer standard of care since something like the 40s. Doxorubicin is not that far off. And so after 50 years, to finally have a better first-line standard of care for dedifferentiated liposarcoma than doxorubicin, huge win.
Absolutely. And that's something we, as a oncology for the Inquisitive Mind team, has neglected, is to do more sarcoma-related episodes.
I always feel really, really ignorant when I start talking about sarcoma, I must say. So I think the solution to that, Josh, is to track down a sarcoma specialist and drag him into a recording booth so we can forcefully extract his wisdom, like those aliens from Space Jam.
Yeah, no, 100%. So we'll move on. As we're harmonizing here, Michael, I'll move on to my next study, which is Harmony 6. And I'm going to give the cliff notes at the front because I got some feedback from our in-person event that they want to know, give me the point. So this is a conversation of, can we do better than chemotherapy and immunotherapy in advanced non-small cell lung cancer, both squamous and adeno? And the answer is yes. So this study compared two drugs, one which is a PD-1 inhibitor, that's tislelizumab, and then the other one, which is ivonescimab, which you might not have heard of, which is a tetrameric bispecific antibody targeting both PD-1 and VEGF. And lo and behold, the combination with the tetrameric bispecific antibody plus chemotherapy did better than the traditional PD-1. But you'll have to keep listening to hear the exact numbers.
A masterful hook, Josh.
Thank you. I'm quite proud for 8 o'clock at night as of time of recording. As you'd probably guess, the arms were the ivonescimab plus chemo versus tislelizumab plus chemo in untreated patients. There was some pre-specified interim analysis of progression-free survival, which was pretty darn promising. 11.1 months versus 6.9 months with a hazard ratio of 0.6. And this is the overall survival analysis at ASCO. Whoa. Chills. 530 patients were randomized 1-to-1. The chemotherapy backbone was carboplatin and paclitaxel. What do you think of that backbone, Michael?
I mean, this study was focused on squamous cell, non-small cell lung cancer, so I think it's reasonable.
It was both, I thought.
I think this particular study was, squamous non-small cell lung cancer. There is a Harmony 3 that is currently ongoing that is enrolling both. But I think that was a real point of differentiation for this, because I must confess, when I was listening to the recording, I thought, what's this? What's the difference between this and the keynotes and all of that? But this is specifically for squamous cell cancer, which is sort of almost an also-ran in the world of non-small cell lung cancer, I believe.
Yeah, that's it, isn't it? And so stage 3, stage 4, an unresectable PD-1 status was also stratified the TPS score, and the primary endpoint being progression-free survival, and the secondary endpoint was overall survival. I'm just going to skip through, Michael, but demographics, most had metastatic disease. A good proportion of patients had a history of hemoptysis, and about a third or 40% of patients had a PD-1 of less than 1%. At data cutoff, 60 patients remained on treatment of the ivonescimab, and 51 patients remained on treatment of the atezolizumab. The median overall survival was 27.9 months versus 23.7 months. Hazard ratio of 0.66 being statistically significant. It was also found irrespective of the pre-specified subgroup. So PD less than 1, not reached versus 18 months, and a hazard ratio of 0.64, and a PDL1 of greater than 1%, also not reached versus 27.3 months, hazard ratio of 0.68. So that cohort did slightly better. So overall, things are looking really great for this drug. Thus, it's the presidential plenary session. Who would have thought? Safety, grade 3 AEs was slightly higher in ivonescimab, as you'd expect. The treatment-related adverse events leading to discontinuation, though, was very similar. So that was 5.3 versus 4.5%, which is what 1 in 20 patients. So not a terrible number. Grade 5, 3.8 versus 4.2%. That's concerning. But in saying that, you have to remember these guys don't have a lot of options, especially if they've got no mutations of which to use. And most of the time, squamous is less likely to have those sort of targeted mutations you see in adenocarcinoma. Grade 3 adverse reactions or immune therapy was 14%. And then you saw some slightly higher VEGF-related AEs, as you'd expect, based on the fact that that is what this trial is looking at. So really interesting questions here, Michael, like how does a VEGF work with the PD-1? Does it do something with the vasculature that changes the way the cancer responds to immunotherapy? Like lung cancer is a fascinating area. But that would be sort of my questions, but it's exciting. And I think I'm looking forward to Harmony 3, which will expand that, because obviously adenocarcinoma is the predominant in the Australian and most of the Western world now, because when a lot of people aren't smoking. And so that will be a real point of differentiator if it ends up becoming mainstream. And don't forget to like and subscribe.
Smooth, very smooth. Yeah, look, I think that, again, squamous cell lung cancer is a study that has, or is a cancer subtype, I should say, that is relegated to second fiddle, as I said. The presenter at the plenary session said that the studies that had looked at squamous cell or included squamous cell lung cancer had been not powered for overall survival. So we actually don't know if carbopac-pembro, which will be standard of care by that logic, actually has an overall survival benefit. I think the other thing of note with the VEGF inhibition and why they probably looked at it so well, Josh, is when they tried to give bevacizumab in the early days, the early 2010s, with squamous cell cancer, people died. People had massive hemorrhages, and the studies were stopped early, and that's why you never give bevacizumab to a squamous cell lung cancer. So that the fact that they've got VEGF inhibition there, which we know does have a therapeutic benefit, is really important. And the fact that it doesn't increase the risk of, major hemorrhagic events or other VEGF-related toxicities to a significant degree, is also very important. And I think that just comes down to the oncological and biotech industry as a whole being far more sophisticated than it was when all we had was bevacizumab.
That's it. And look, it's the same as antibody drug conjugates. But Michael, you are truly a little book. You're a text, you're a scripture, you're a opera, a musical. But why don't you tell us about the next study that you have planned?
Josh, your wife would be very proud of you. For those of you who don't know, Josh's wife is a very talented opera singer. So for Josh to throw that in, I'm sure it's a shout out to her. But yes, this is the libretto study, not from Italy. It's actually from the University of California, of all places, where it was presented by Dr. Jonathan Goldman from the University of California. But Libretto 432 is another lung cancer study, and following the theme thus far, it's lung cancer, but it's also a rare subtype of cancer, and that is with RET fusion. It's a study of adjuvant selpercatinib in stage 1B and to 3A RET fusion positive non-small cell lung cancer. Now, I'm going to shamelessly crib off Josh's presenting style and give you the Cliff Notes version, which is, will this have a benefit? Yes, it will. That's why it's in the presidential session, and you probably didn't need me to tell you that. But a little bit of a background. Rearrangement during transfusion gene, which is what RET stands for. Josh, they always come up with the most amazing names for these genes. Encodes a cell surface tyrosine kinase receptor, which is frequently mutated in amongst other cancers in medullary thyroid cancer. But it also occurs in 1 to 2% of non-squamous non-small cell lung cancers. And as the title suggests, this usually takes the form of a fusion mutation. There is no adjuvant targeted therapy currently approved for early stage RET fusion positive non-small cell lung cancer. Not surprising given how long it's taken for us to get adjuvant EGFR and adjuvant ALK therapy, to say nothing of KRAS. But selpercatinib is a highly selective, potent, brain-penetrant RET inhibitor. And based on the previous Libretto 431 trial, and yes, I will say it in that accent, Josh, you can't stop me, it is approved for RET fusion positive advanced metastatic non-small cell lung cancer based on improved progression-free survival versus chemotherapy. So this is the study design, and again, rare cancer, but they somehow managed to find 151 patients with RET fusions. 21 patients had stage 1B disease, and so therefore, as you can see here, weren't included in the primary analysis, which was focused on patients with stage 2 to stage 3A disease. The primary endpoint was event-free survival in this cohort. Secondary endpoints were EFS by blinded independent central review in the primary analysis population. Gosh, try saying that 5 times fast. Also, EFS by investigator and BICR in the overall population, where we stick those 21 patients back in, safety and overall survival. So the study was of selpercatinib, 160 milligrams twice a day, so it is oral, versus placebo for up to 3 years after definitive therapy. And definitive therapy could be surgery, it could be chemoradiotherapy, but basically it is a definitive therapy aimed at long-term control or response. Patients were stratified by stage and the type of definitive treatment that they had. Spoiler alert, most people had surgery. Crossover from placebo to selpercatinib was allowed on disease recurrence as well. So again, much like SARCO 041, keep that in mind when we're looking at the results. This was an international study, kind of had to be for such a rare cancer. And the primary analysis population was 109 patients. The two cohorts were actually incredibly well balanced. I do like to try and go through these and nitpick slightly, but I don't think I have very much to nitpick here. Very well balanced. As you can see, the vast majority of patients had prior anti-cancer therapy in the form of surgery, with maybe a sprinkling of chemotherapy on top. So let's come to the results, the juicy bit, as Josh likes to call it. The median follow-up, I should say, was 24 months for selpercatinib and 27 months for placebo. And the event-free survival, as you can see here in the stage 2 to 3A, so the primary analysis population, was not reached versus 31.8 months. Now, Josh, how's this for a hazard ratio? 0.172. I think that has to go into the Hall of Fame.
It does. We have not visited the Hall of Fame recently, Michael, but 0.12 would make all the Top Gear guys really excited.
Well, our previous Koenigsegg equivalent was, I think, osimertinib, and that has had a ratio of 0.2 or something. So yeah, this is absolutely fantastic. Small numbers of events, I will say. So 4 events in the selpercatinib arm versus 19 events in the placebo arm. The EFS by in the overall population followed a similar pattern, hazard ratio of 0.165. So I think it's safe to say that those stage 1B patients that may have done well anyway are not necessarily driving the benefit, and I think that's why they divvied it up, which is a good way to do it. Now, blinded independent central review, very important, but no significant changes from them compared to the investigator-assessed review. And in key subgroups, most of these are completely fine. Some of the ones do cross the line of equivalence, probably due to small numbers. If you're watching on YouTube, you can see that the number of events is in the single digits throughout the selpercatinib arm. That's probably not enough to draw any significant conclusions. Now, the overall survival data, as you can probably imagine, are immature, but at 2 years, no deaths were reported in the selpercatinib arm versus 3 in the placebo arm. So these patients are doing well regardless of what we're doing, but selpercatinib, as we saw by that fantastic hazard ratio, is clearly better. 55% of patients remain on treatment at the time of data cutoff, so you have a really good sort of success rate for these patients. Now, in terms of safety, the treatment-related adverse events of grade 3 or higher in the selpercatinib arm, I'm going to ignore the placebo arm, was 66.7, so 2/3. The most common AEs of any grade were increased AST and ALT, dry mouth, diarrhea, and hypertension, so things to watch out for if you are using selpercatinib. Adverse events of special interest include hypersensitivity, so 6.7% had a grade 1 to 2 hypersensitivity, which from memory was a syndrome of fever, basically an allergic reaction similar to what you'd see in a paclitaxel reaction. But importantly, no patients had a grade 3 or higher severity hypersensitivity reaction, and QTC prolongation on the ECG, where 9% of patients had a grade 1 or 2 QTC prolongation and 1.3% had a grade 3 or higher. 2 patients discontinued selpercatinib due to serious adverse events, but no patients died due to study treatment. And that's basically what I'm saying in a separate way, in a different graph. So this is a rare subtype, Josh, and, selpercatinib is obviously not going to be for everyone, but I just can't get past that hazard ratio. It is a phenomenal hazard ratio, and I really do look forward to seeing how the overall survival shakes out, not just because these are patients who I'm guessing, given that the follow-up is, getting close to 3 years or more than 2 years, these are patients that are probably going to be cured. So how much benefit is there going to be? But also the fact that selpercatinib is allowed on progression in the placebo arm. So that crossover is going to erode any overall survival benefit. And if we get any sort of hazard ratio, that's going to be good.
Yeah, fair enough. I was talking to someone about this. It's a rare mutation, but you keep adding all these mutations when it comes to these sorts of cancers. It actually builds. It's not just, it's 1 + 3 + 5 + 8%. Like, there's actually a section of the lung cancer community who will respond to a treatment, whether it's ostomy. Yeah, so I'm not going to get into that, but like, if you actually look at the block, the more mutations they can treat, the more treatable this cancer, which, remember, KEYNOTE 189 hasn't been around that long.
Yeah, relatively speaking. No, but I completely agree. And the more tools we have in our toolbox,
the better.
That's never a bad thing. But Josh, I'm not even going to try and do a segue for this, because the next study is called PROTEUS. If you have any funny segues that could have led to us to the PROTEUS study, please leave a comment or send us an email at inquisitiveonc@gmail.com.
That's it. And 5 stars. But just in case you got this far in the episode. So the fourth episode,
it just feels like the fourth episode at this point, Josh.
Oh, God. I know. But look, it's to talk about prostate cancer. It's really the idea of high-risk prostate cancer if you give perioperative therapy in the form of ADT plus an ARPI, androgen receptor pathway inhibitor, or an RC, androgen receptor signaling inhibitor. I prefer that one personally. With apalutamide, do you improve PCR, minimal residual disease, and metastases-free survival? The outcome of this is overall yes, with some caveats to that point, but keep listening and I'll explain what I mean in a second. So the standard of care is a radical prostatectomy, and it's potentially curative. And then for those that are older, sometimes they'll give radiotherapy. And then you're in the MBM, and then people like to fight about it. Not the oncologist, because we don't have much to do with the at least in Australia, this cohort of patients, but definitely the other specialists. The specialists like to have strong conversations.
Specialties who shall remain unnamed.
Yes, because they're special. The issue with these high-risk guys who have nodal involvement is that their recurrence rate is high. And that time to metastases, relapse, and death, they say is 3 to 5 years. I think when you look at the data points and with the explosion of treatment options in prostate cancer, there are people who live 10, 15, 20 years, and you're just like, have we cured you? Like, that is true. So there were 2,000 patients in this trial, somewhat different to your differentiated sarcoma trial of 109. So, we got the men we needed. They rose up for the challenge. They were enrolled with a new diagnosis of high risk, and it was histologically confirmed. You had to have a PSA, N0, N1 on conventional imaging, already a point of problem. And the problem with that is that we've got PSMA PETs now, and that's only really become standard of care in the last 3 years, at least in Australia.
I will say, Josh, just as a point of just to prevent angry comments, because I know we get angry comments. We probably don't. You guys are all lovely, but they did actually do an amendment to address your bugbear, preemptively address your bugbear, allowing PSMA PETs when it became standard of care.
Yeah, but there was still a cohort of patients who did not get that. So yeah, I was aware of that, but it's still like there's that issue. Anyway, besides the point, that was still a limitation of this specific study. They were then stratified depending on their Gleason and their region, and they're randomized 1-to-1 to either apalutamide plus placebo plus ADT for 6 months in the neoadjuvant setting, with a 2-week break and a 4-week break after treatment, followed by 6 months to the assigned therapy. The sub-study enrolled 400 patients comparing RP alone or to APA plus ADT plus RP, and that is currently ongoing in that cohort of patients. There were dual primary endpoints being pathological complete response and MRD, which was minimal residual disease. I got there eventually. And a YPT2 and less than 5 millimeters tumor diameter, and metastases-free survival based on conventional imaging or PET, as Michael so eloquently mentioned. There was no agreed criteria to response to neoadjuvant therapy in the prostate cancer, because I guess this is a novel approach, right? We don't generally do that. Secondary endpoint, event-free survival, time to first subsequent treatment, time to distant mets, and safety. What is missing here, Michael?
Overall survival.
Yeah. And whilst I appreciate prostate cancer patients live a long time, that is a question. It is a question. Gone.
No, sorry. I was just going to say, especially when you're putting highly effective treatment front and center, first line, that's always the question: is sequencing.
Right. And look, maybe you can re-challenge because they don't become resistant, but it's sort of these are guys that live a long time. So if it's like a breast cancer patient, I want to know, am I actually helping these guys, or should we just chop out their prostate and be done with it? Because apalutamide and ADT does have toxicity. And whilst it's very usually manageable, I get on a high horse. So thank you for letting me do this trial anyway. So average age in their 60s, PSA at least 20, median follow-up was 61 months, which is not a long time for really an early prostate cancer. 5-year metastasis-free survival was 78.2 versus 73 months, statistically significant with a 0.74 hazard ratio, and the pathological complete response and residual disease rate was 8.9 versus 1%, with an odds ratio favoring the pathological complete response. And the metastasis-free survival by blinded independent clinical review had a hazard ratio of 0.8. The event-free survival was 0.71, again favoring apalutamide, and the time to subsequent treatment was 74 months in the APA group versus 41 months in the placebo group, also statistically significant with a hazard ratio of 0.65. But then you ask the question, you've now reintroduced ADT. And so then my point is like, okay, so I gave this guy 5 years without treatment, maybe 6 versus 3.5. And I say male because obviously men have prostates, women don't. And that's just, it's, I guess, I when I go to offer someone a treatment, I like to say, this is the reason why, this is what the data shows, this is what we can extrapolate with beyond reasonable doubt. Michael, look, and this is the thing. So grade 3 for AEs, 39 versus 31%, discontinuation 7 versus 2. So almost 3 to 4 times the discontinuation rate with these patients. And subsequent therapy, 56 in the control and 42 in the intervention arm, and systemic therapy 26 versus 36%, still favoring the control arm having more people needing subsequent therapy. And so the summary, because Michael he will give the absolute final talk of our trial. He is relishing at that idea. Is that for this trial, like, I love the idea they're doing a perioperative study. I need an overall survival point for that. And I think that's really important when you're going to castrate a man.
I think that's very fair. It's something that I'm sure will come. But yes, it is probably a bit early for us to be throwing apalutamide, do you think? If you let me put it to you this way, Josh. Based on the data that you have, you as our resident GU aficionado on this show, if you had access to apalutamide in the perioperative setting, would you use it?
I think it depends. I think so. This is kind of my thing. If it's a 50-year-old with a high risk thing, I'm like, would I be more convinced to try and give this man everything, to try and delay it, knowing that he might recur and we've still got 25 years, we need to try and extend this. But if the guy is 65 or 70 and he gets 4, 5, 7 years, and I know that's the pushing that limit that I've spoken about, and he didn't need anything, and then I put him on intermittent ADT for another 8 years, or ADT plus an RP for 8 years, and he gets to his 81st birthday and I've saved him all that toxicity in that first sort of 6-7 years, potentially I would omit it. I mean, I guess the thing is, I'd never like to say no because people like give me everything. I think it's just a bit of a conversation, really. And you've got things like pelvic radiation you can use to try and reduce that recurrence. They've got biochemical recurrence. There's lots of sort of nifty tricks you can sort of look at with these guys if they do have recurrent disease. So I think I like the trial. I like what it's saying, but I think just erring a bit on the side of caution when there's no OS data in a cohort of patients who live a long time.
So what you're saying, Josh, is that you wouldn't stumble blindly into following what potentially may be a phase, as it were. That's probably a bit unfair, but you would be judicious and select your patients carefully.
No, that's the scapegoat answer. Yes.
Very good. Very good. A very reasonable answer. Well, look, there is no need for such equivocations with our last study because, yes, Josh spoiled it. I have been greatly looking forward to talking about this study, and I have been resolute in my conviction that this is an absolute star, not just of this ASCO, but I think of many, many years, because this is a study of daraxonrasib, and I've been practicing to get that right, which is a RAS-on multiselective inhibitor versus chemotherapy in previously treated metastatic pancreatic cancer. This is the primary and final analysis from the phase 3 Resolute 302 study, and there was many a standing ovation, the first of which, it must be said, was spontaneous. And you too might spontaneously leap out of your seats, and if you're driving, please don't do that. That's unsafe. But when you hear this data, hopefully it will make you happy because, spoiler alert, this, for my money, is the most impactful study presented at ASCO. The background here, anyone who treats cancer at all knows that there are bad cancers and then there are bad cancers, and pancreas cancer is most definitely in the latter group. It is one of the most challenging cancers to treat, with high morbidity, poor prognosis, and the poor efficacy of therapies beyond the first line. There's not a whole lot of data beyond the first line of gemcitabine plus nab-paclitaxel, gemabraxane, or FOLFIRINOX. And we've talked about the liposomal irinotecan and the nilirifox and all that sort of stuff, but none of them have really shifted the needle. The reported median progression-free survival of second-line therapy is about 3 to 4 months, and the median overall survival is about 6 to 7 months. I will say that in my own experience, it's considerably less than that. And this is completely discounting the significant proportion of patients who never make it to second-line therapy. Aberrant RAS pathway activation is a key driver of pancreatic ductal adenocarcinoma, and mutations are present in greater than 90% of cases. And we've known this. This is one of the most frustrating things about pancreatic cancer, is we've known that this is a potential driver. But KRAS for a long time, and not just in pancreatic cancer, but in lung cancer and in colorectal cancer, has long been thought to be a nigh undruggable target until now. So the most common types of RAS mutation in pancreatic cancer are G12, in the codon of G12, most commonly G12D, V, and R. The one that's missing there, of course, is the famous G12C, but that's less common in pancreas cancer. So the methods, let's just jump right into it because I am frothing at the mouth. They enrolled 500 patients in Resolute 302, and eligible patients had to have an ECOG performance status of 0 to 1. They had to have at least one prior fluoropyrimidine or gemcitabine-based regimen in the metastatic setting, so that's discounting any sort of perioperative neoadjuvant stuff. And they had to have a documented tumor RAS mutational status. Interestingly, it was by local testing. A lot of these studies will mandate central testing, but local testing is generally quicker. Of course, there are some quality trade-offs that you might have to make, but you sort of trust the process. Stratification factors were by ECOG performance status, whether they were de novo metastatic, whether they had liver metastases at baseline, and the type of tumor RAS mutational status. And this is important because this stratification was RAS G12D and V versus other RAS G12 versus RAS G13 or Q61, the far less common mutations, or no RAS mutation. There were dual primary endpoints of overall and progression-free survival in the RAS G12 mutant cohort, and that's important because this is a pan-RAS blocker, as evidenced by the number of subtypes. If you look at, for example, sotorasib or adagrasib in lung cancer, they are targeting specifically KRAS G12C. So if you have G12D, and I've had patients that I want to put on one of those KRAS inhibitors, it's the wrong KRAS mutation. So this is a drug that it doesn't really matter what type of KRAS mutation you have, this is an option. Secondary endpoints were overall and progression-free survival in the overall population, overall response rate in the RAS G12 and the overall populations, and the treatment outcomes and the patient-reported outcomes in the RAS G12 and overall populations. Yes, so 500 patients, and I'll draw your attention to this little bit at the bottom, patients who are having ongoing treatment. In the daraxonrasib arm, 42% of patients with a median follow-up only of 8.5 months. But remember, this is pancreas cancer where time is almost always short. This is compared to 14% of patients in the sort of standard of care. In terms of the chemotherapy options, the majority of patients in the second-line cohort had gemcitabine and paclitaxel, 57%. A surprising cohort of patients had Nelliri plus 5-FU, so FOLFIRI with the irinotecan being liposomal. That's 33%. And then FOLFIRINOX, 6%, and FOLFOX, 5%. Baseline demographics were well matched. Liver metastases at baseline, 70% in both. Only a third of patients had a prior pancreatectomy, so you can get from that more than 70% of patients were de novo metastatic. And 78% of patients had a RAS G12D or RAS G12V mutation. Only 8% had a RAS G13, Q61, or no RAS mutation identified, which shows just how common RAS is in pancreatic cancer. Now, if you're watching this on YouTube and you want to jump out of your chair, now is the right time because this is the overall survival. And remember, this is in patients who have already had a line of therapy. Thank you, Josh, for jumping out of your chair. So the overall survival was 13 months in the daraxonrasib arm compared to 6.6 months in the control arm, with a hazard ratio of 0.4, which of course is statistically significant, and you have this beautiful Kaplan-Meier curve with clear separation. Interestingly, the upper limit of the daraxonrasib arm was not reached. So much like the patients are still getting treatment, you have patients who are just responding, which never happens in pancreatic cancer. Overall survival in the overall population, remember, a significant proportion, or not a significant, but a proportion of patients in this population doesn't even have a KRAS mutation, and yet the results are still the same, with a hazard ratio of 0.4. The subgroup analysis, beautiful forest plot where the only subgroups that cross the line are the subgroups with very, very small numbers. So when they say consistent across subgroups, this is pretty consistent across subgroups. Progression-free survival, very similar story in the RAS G12 population, hazard ratio of 0.45. Overall population hazard ratio of 0.49. Overall response rate, again, much higher. You're tripling the overall response rate, 33 compared to 11 in the G12 population, 31.6 compared to 11 in the overall population. Now, in terms of safety, yes, you're going to have toxicity. The most common toxicities with the daraxonrasib arm were rash, 17.4%, and stomatitis at 6.6%. Chemotherapies I'm not going to go through because we sort of know what they're going to have. In terms of treatment-related adverse events leading to treatment discontinuation, daraxonrasib, 1.2%. 2 patients ceased due to a maculopapular rash, and 1 ceased due to elevated liver function enzymes. Compare that with chemotherapy, where it's 11%. So this is, what I call the having your cake and eating it too type of treatment, where you have better efficacy and fewer side effects. The holy grail of any sort of oncology treatment. If you can prove that, then you are on a fast track, as the study, as the Resolute authors are, to a ASCO plenary session. In terms of patient-reported outcomes, and this is just the cherry on top, Josh, again, a far longer time to deterioration in terms of pain and the global health status or overall quality of life in the daraxonrasib arm. So I don't think there is a cohort or sort of a criteria where you wouldn't use daraxonrasib if you have access to it. Now, there is going to be, and I think it's actually opening in a hospital, at least up in Brisbane, fairly soon. There is going to be a first-line study for daraxonrasib, and that will be really interesting. I'm also curious, given that the toxicity rates seem to be quite low, about whether anyone would have the courage to combine it with chemotherapy. Probably less beneficial given it's pancreas cancer, and we know chemotherapy doesn't really work too well. But I mean, Josh, you wanted a strong one to end. I think I know I'm gushing. But I think that daraxonrasib may be the next TDXD, not necessarily in terms of efficacy, but it's a drug that I think we're going to see pop up everywhere. We're going to see it pop up in lung, and we're going to see it pop up in colorectal. And if there is a whiff of KRAS mutation in any tumor stream, daraxonrasib is going to be there lurking in the shadows, much like TDXD is for HER2 positive cancers. So Josh, brilliant. Massive congratulations to the authors. Huge congratulations to every author who presented at the plenary session, everyone who presented at ASCO. It was a great conference. And I think there is no better spot to end than a potential breakthrough for patients with pancreas cancer.
Yeah, and I think the reminder of why we do this is these are great trials, but it's for that patient behind the screen and that patient who needs a better option. So, to all the patients who give their lives up to be on these trials, and for those that respond, amazing. And for those who leave their families and friends behind, it's a sad moment. I don't mean to rain on your parade, Michael, but it's important to
It is
remember.
Important. And, there's a reason that every oral presentation at any conference, quite rightly, ends with a thanks to the patients, because quite literally none of this could happen without them. So
That's it.
Every oncologist and every patient that comes after is indebted to the ones that have gone before, built on the shoulders of giants, as it were, Josh. So, yes, I think we and everyone extend our heartfelt gratitude to the patients, the scientists, the statisticians, the doctors who did all of these great trials, and we cannot wait to see, and the nurses, everyone involved. And we cannot wait to see what comes at ESMO this year and ASCO next year. And Josh, there's a bit of a break between our major conferences because this hasn't taken 1 million episodes to get through.
There we go. And maybe you and I will take a week or two off, but we can talk about that off screen. We'll see you next time.
Bye.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.